working on now since 2014, really since I joined McMaster as an early faculty member post-fellowship. These are my disclosures, which essentially the most relevant ones are that I've worked with several companies that produce direct-acting oral anticoagulants, as well as companies that produce either direct or indirect reversal agents for anticoagulants, which will be relevant to today's talk. Our objectives are to, one, today discuss the dilemma of if and when to reinitiate antithrombotic therapy following ICH, review emerging observational and randomized trial evidence on this topic, and then highlight current guideline recommended management and relevant ongoing trials. The first thing to take home and realize is that, of course, this is going to be a problem that's going to increase with our aging population, in that the diseases that necessitate antithrombotic therapy, like vaso-occlusive diseases or cardioembolic diseases, are age-related, as are vaso-occlusive diseases that contribute to ischemic stroke, and as are the hemorrhage-prone cerebral small vessel diseases that contribute to ICH. And thus, these diseases are not only going to increase individually, but their comorbidity in the same individual will also increase. So this is going to be a challenging dilemma that we face more frequently on the wards as our population ages further. And already is actually quite frequent to face patients that have competing ischemic vascular diseases and who are presenting rather with ICH, and that in the review of 1 year's worth of ICH admissions at our hospital, we found that about 1/5 of patients had a history of atrial fibrillation. Close to 1/5 had a prior history of coronary artery disease or MI. 1 in 10 had prior history of ischemic stroke. Another 1 in 10 had prior history of TIA. And antithrombotic therapy was being used at onset in about 1/4 of patients, statin therapy in 1/3 of patients. I won't get into the dilemma of statin therapy today, but of course that's another compelling question that's being kind of answered by the ongoing Saturn trial. And then lastly, actually, almost half of the population, you could have found an indication for antithrombotic therapy. And when you're trying to decide whether to resume or initiate antithrombotic treatment after an ICH, what the challenge dilemma that we face in discussion with patients is really balancing the benefits of antithrombotic therapy for these ischemic diseases or cardioembolic diseases, and roughly antiplatelet therapy reduces the risk of ischemic vascular disease and vascular events from coronary artery disease and ischemic stroke by about 20%. And anticoagulation for in the context of atrial fibrillation, you have a much more robust effect size of about a 70% relative risk reduction in patients with AF with anticoagulation for reducing the risk of ischemic stroke. But that needs to be balanced against a heightened risk of recurrent ICH with antithrombotic therapy and the potential for larger, more disabling and lethal strokes should those bleeds occur on anticoagulation. And then conversely, in the setting of AFib, not only does anticoagulation reduce the incidence of ischemic stroke, but we also know that the breakthrough ischemic strokes that occur on anticoagulation tend to be less disabling in smaller and resulting in smaller infarcts with more distal occlusions. So these are really the competing risk and benefits when thinking about initiation of antithrombotic therapy in patients with ICH. And of course, it comes down to it being disease specific. Just initially starting with antiplatelet treatment after ICH, irrespective of the indication, really the best evidence we have is the randomized RESTART trial, which was led in the UK by Professor Salman. And these were any patients that came in on antithrombotic treatment. There was a very small proportion of these patients that had AF, and ultimately they were randomized to antiplatelet therapy or placebo post-ICH. And what was quite surprising in looking at the primary outcome results of this trial was that resuming anticoagulation in the blue line actually had less recurrent symptomatic ICH than avoiding anticoagulation in the red line, and this was a 49% relative risk reduction. And the confidence interval for this endpoint, effect estimate ranged between 0.25 up to 1.03. So at most a 3% excess risk of recurrent ICH within the precision of this endpoint. And of course, this was quite surprising to us because previously in non-ICH patients, we've seen a 20% increased risk of incident ICH or someone's first ICH with antiplatelet therapy. And the question still remains, is this a valid finding in that anticoagulation may actually reduce recurrent ICH? Or is this really just a reflection of the poor power of this trial and the potential for chance findings? In that, remember, this was a phase 2 trial with just over 500 participants. And really, we need a much larger study to answer this question definitively. But what it does provide is reassurance that it doesn't seem harmful to resume antiplatelet therapy, that you don't get excess recurrent ICH. And that what the trial did do is replicate the 30 it showed actually rather a 35% risk reduction in all major adverse vascular events in patients with ICH with antiplatelet therapy versus avoiding antiplatelet therapy. So there was a benefit that was seen for major vascular events, ischemic vascular events, and no major suggestion of excess bleeding, and if anything, a numerical reduction in bleeding. However, another question that one may pose is that, well, what about higher risk phenotypes of ICH, such as patients that have cortical superficial siderosis, those with lobar ICH, or those who have multiple microbleeds, which we know either indicate underlying cerebral amyloid angiopathy, which is a high risk of recurrent hemorrhage, or more aggressive phenotypes of hemorrhage-prone cerebral small vessel disease, or rather arteriolosclerosis. And what we find actually when looking at a subgroup analysis from the RESTART trial is that it didn't really matter whether you had a lobar ICH at onset, whether you had focal or disseminated superficial siderosis, whether you had multiple microbleeds or strictly lobar microbleeds, or if you fulfilled the Boston criteria, the point effect estimate was always favoring antiplatelet therapy resumption in terms of for the outcome, primary efficacy at point in this trial, which was recurrent symptomatic ICH, which provides further reassurance in this regard. Now, I will caution you that the RESTART trial also published this longer follow-up study that had a median follow-up of 3 years with an IQR of 2 to 5 years, which actually showed some attenuation of the effect sizes, both for recurrent symptomatic ICH, as well as the risk of first occurrence of major vascular event. In that for recurrent symptomatic ICH, here now, the adjusted hazard ratio is 0.87, and your 95 confidence interval now increases to 1.55, including that 20% excess risk of bleeding that we've seen in non-ICH patients. So with greater follow-up and increasing events, the safety reassurance becomes less definitive. And in addition, the effect size on major vascular events is actually attenuated as well and no longer statistically significant, but more closely resembles that 20% reduction in vascular events that we would expect. And on the basis of these trial results, several guidelines have been modified, and we now indicate that it is reasonable to resume antiplatelet therapy in patients who do have an indication for it after an ICH, but these are kind of level B recommendations, and we really need a definitive trial. And this is where the aspiring trial comes in. This is a trial that's led by Dr. Salman, who led RESTART, but is now a global study where so far we've gotten additional funding in Australia, Belgium, Canada, and the Netherlands, and we're constantly seeking additional national funding to expand the trial globally because we have this ambitious target of 4,000 patients with ICH to be able to demonstrate a benefit with antiplatelet therapy versus not in ICH survivors. And what interesting aspect of this trial design is that on the basis of a lot of work that has shown over the past 5 to 10 years that patients with ICH have a very high risk of ischemic vascular events in addition to recurrent bleeding after their ICH, irrespective of whether they had a prior symptomatic ischemic vascular event or irrespective of whether they're already on antiplatelet therapy. This trial actually allows the enrollment of anyone with a prior ICH, irrespective of their ischemic comorbidities or whether they were already on an antiplatelet agent prior to enrollment. And we'll be launching this study in early next year. And hopefully we'll have some results over about a 6-year time frame. Now, let's switch to AF-related ischemic strokes. Here, we know that the ischemic strokes that result from AF tend to be very large, disabling ones because they tend to occlude proximal vessels that lead to large territorial infarcts. And we have very robust evidence, as I mentioned, for the benefit of anticoagulation versus no anticoagulation in these patients. Historically, the randomized trials that compared warfarin versus no anticoagulation showed a 64% reduction in any stroke. And if you look at ischemic stroke in isolation, it's a 67% relative risk reduction. Now we're in the era of direct oral anticoagulants, where there's an additional 20% risk reduction in all stroke compared to warfarin with NOACs, and this is being driven predominantly by a halving of hemorrhagic stroke, which of course is of interest when you're thinking of anticoagulating patients after an intracerebral hemorrhage. So the favorable safety profile of these agents has really allowed us to think about this more consistently and really design randomized trials to answer this question. As I mentioned, in our hospital, about 20% of patients presenting with ICH have prevalent AF, and this seems to be fairly consistent with studies published in the Western Hemisphere and in high-income countries where the incidence is about 16%. In East Asia, however, the incidence is a bit less, and the reason for that is that the ICHs in East Asia tend to occur about a decade earlier. So patients haven't had the chance to develop AF at the time of their presenting ICH. But for Europe, North America really is about 1 in 5 or so. And because patients with prior ICH were excluded from all the randomized trials that have tested anticoagulation versus no anticoagulation in patients with AF, and the pivotal trials that really established the benefit of anticoagulation, guidelines are not able to provide any firm recommendations in this regard. And the ESO currently states we cannot make firm recommendations due to the absence of RCTs. The Asia-Pacific Heart Rhythm Society indicate that NOAC can be restarted in patients that have a CHA2DS2-VASc score of 6 or greater and low ICH risk. This data comes from a national registry study looking at where they thought in this observational data set the net benefit lied in patients treated with warfarin. So I think this cutoff is way too high of a cutoff for patients who are being treated with NOACs. In Canada, we indicate that it should be individualized according to patients' risk of recurrent ICH with thromboembolism, and that DOAC therapy is favored over warfarin based on its safety profile in non-ICH patients. And in the AHA guidelines, it's currently written that non-valvular AF and spontaneous ICH, the resumption of anticoagulation to prevent thromboembolic events and reduce all-cause mortality. And I'll highlight the wording of reducing all-cause mortality because it comes from observational data that I don't believe will generalize to the RCT evidence, and I'll show you why, may be considered based on weighing benefit and risk. So as you can see, the fairly vague wording that doesn't provide anything conclusive to help us, but we really individualize it to the patient. And this is what physicians are currently doing. This is a survey we conducted among stroke neurologists, neurosurgeons, and thrombosis experts, and we saw that, unsurprisingly, due to the lack of hard evidence, there was a variability in resumption between 30 to 98%, depending on the respondents and the clinical case scenarios that was presented to the physicians. Where physicians felt most comfortable resuming anticoagulation was after head trauma, where 98% of respondents would have eventually resumed anticoagulation, again, thinking that the inciting trauma was one isolated event. and as long as you can prevent falls in the future, there should be a reduced risk and not of concern. And then where there was the greatest reluctance to resume anticoagulation, but where 1 in 3 physicians was still resuming anticoagulation was in the context of cerebral amyloid angiopathy. And the respondents were sophisticated enough to differentiate CAA from lobar ICH, where actually 70% of respondents indicated they would resume anticoagulation, and that not all lobar ICH are due to CAA, although the vast majority, once you're over the age of 70, are. And why this kind of dichotomy between lobar and non-lobar ICH? Well, as we know, because the risk of recurrent hemorrhage is very different depending on the underlying microangiopathy that contributed to that bleed. And deep hemorrhages or non-lobar hemorrhages really are due to a hypertensive arteriopathy, where the risk of recurrent ICH is about 2 to 3% per year. And lobar ICH is predominantly in the elderly, are predominantly due to cerebral amyloid angiopathy, where as a whole, all lobar ICHs have about a 5% risk of recurrence per year. If they have additional imaging evidence of cerebral amyloid angiopathy, that increases to 7% per year. However, if you then dichotomize those that meet Boston criteria for CAA to those that have disseminated cortical superficial siderosis involving 4 or more non-contiguous sulci, the risk is dramatically increased to 13% per year. However, in the absence of disseminated siderosis, even if someone has multiple lobar microbleeds and so forth, as a whole, when you exclude those highest risk patients with disseminated siderosis, the risk, even in patients with CAA, goes back down to about 5% per year. And what are our treatment options for patients with ICH at present? Well, 1 is standard dosing NOACs. 2 is using off-label low dosing of NOAC. And there's also evidence now for a 15 milligram daily of edoxaban through a trial called ElderCare AF, where patients who were Japanese and elderly who were otherwise not deemed to be anticoagulant or deemed to be safe for anticoagulation were randomized to edoxaban 15 milligrams daily versus placebo. And in those patients, actually, anticoagulation significantly reduced the risk of recurrent ischemic stroke or systemic thromboembolism without significantly increasing major bleeding or ICH, although recurrent ICH were few and far in between. However, it is worth noting that 80 participants in this trial did have a prior history of ICH, and we did include them in a individual participant data meta-analysis that I'll show you a little bit later. Other options are considering these patients for left atrial appendage occlusion and antiplatelet therapy, antiplatelet monotherapy. You can also consider left atrial appendage ligation or clipping, where ultimately you may not require any antithrombotic therapy whatsoever, but of course the procedure is more invasive, requiring at the very least a thoracoscopy or even sternotomy. And then alternatively, you can treat them with nothing at all. We didn't really have much evidence, even observational data, up until about 2015, where 2 large national data sets from Germany and Denmark were published on this topic. And here is a aggregate meta-analysis or study-level meta-analysis of all the data to date up until 2017 that was led by Santosh Murthy and colleagues. And interestingly, this meta-analysis, the effect size of anticoagulation versus no anticoagulation for preventing stroke on the left does replicate the what we would expect, about a 66% risk reduction that we saw in the original trials of warfarin versus no anticoagulation. However, what is surprising is that when you look at on the figure on the right, and when looking at the effect of anticoagulation versus no anticoagulation for recurrent ICH, we see absolutely no excess risk. And this is particularly surprising because over 90%, and even actually over 95% of the data that contributed to this meta-analysis came from resuming anticoagulation with warfarin rather than the safer alternative of direct-acting oral anticoagulants. And we already have seen previously that warfarin roughly doubles the risk of ICH in patients who have never had a prior bleed who got into the original trials. So one can look at this in a glass kind of half full or optimistic lens and say, well, maybe there's something different once you've had a recurrent ICH, where actually the effect size of recurrent ICH is less than what we see in non-ICH patients. Or I think you could be a pessimist and maybe even a realist and conclude that this is really confounded data, and the most obvious confounding is confounding by indication, in that the decision to resume anticoagulation is not random. It's being driven by physician decision making, and they're likely picking patients who are safer and have more benign natural histories for recurrent bleeding to resume anticoagulation within. And in patients that have high risk of recurrent ICH, they're not receiving anticoagulation, and hence you're getting this artifact of safety that is confounded and not reflective of the true effect. However, one study that takes this a step further was these individual participant data meta-analysis of 3 observational studies of the MGH-ICH registry, the Retrace multi-center German registry, and then the US ERIC project. And across these 3 studies, they identified 1,000 anticoagulant-related ICH survivors with AF. And what was unique here is that they were able to separate those that had lobar and non-lobar ICH, which is important, as I mentioned, due to their different natural histories, as well as the fact that physicians tend to be more reluctant in the latter group versus non-lobar ICH. In total, about 2/3 of the population was non-lobar ICH, 1/3 was lobar ICH. Anticoagulation resumption here wasn't as dramatic in terms of differences as we would have expected. About 28% resumed anticoagulation after non-lobar ICH, and a quarter resumed anticoagulation after lobar ICH, with a median time to resumption about 35 to 44 days. And what was surprising is that there was really no difference whether someone had a qualifying non-lobar or lobar ICH in terms of their response to anticoagulation, and that there was a large reduction in mortality benefit whether you had a lobar ICH or non-lobar ICH with the resumption of anticoagulation. And this data really drives the wording in the AHA guidelines regarding the large potential for mortality benefit with resuming anticoagulation. A 4-fold favorable increase in the MRS at 1 year. So having an MRS of 0 to 3 at 1 year, there was a 4-fold greater likelihood of this good outcome being achieved if someone was on anticoagulation versus not. Reductions in ischemic stroke, which you would expect. And again, no difference in recurrent ICH. Even the hazard ratio was similar, 1.17 in non-lobar ICH groups, and then 1.26 in the lobar ICH group. And again, this is quite surprising because over 90% of this data is looking at resuming anticoagulation with warfarin and not safer direct oral anticoagulants. And really confounding by indication remains, even though this does take us a little bit further in that they were able to differentiate lobar and non-lobar ICH. And then, as I mentioned to you, not everyone with lobar ICH has CAA. And in the smaller sample of 200 patients where they were able to actually identify whether these patients had probable CAA or not, again, there was a 70% mortality benefit with resuming anticoagulation and a 3-fold increased likelihood of having a favorable outcome at 1 year. Here they didn't have the power to look at recurrent ICH or ischemic stroke. And based on this data and other observational data in the field, there was a debate at the ISC in 2018 between Stefan Meyer and Alessandro Biffi, who was the lead author of that IPDMA I just showed you. And the statement that was being debated was that anticoagulation therapy should not be restarted in patients with anticoagulant-related lobar ICH. And here, 62% of the audience disagreed after the debate, indicating that they disagree that it should not be restarted and that or that it should be restarted. 30% agreed that it should not be restarted, and then 8% remained undecided. Since then, there's been the completion of 3 phase 2 randomized trials. NASPA-FICH was their first small pilot feasibility study we completed in Canada. This was followed by SOSTAR in the UK and then Apache AF in the Netherlands. This kind of the crude aggregate of all 3 of these studies is 332 participants with a median follow-up of 1.5 years. These 3 studies, plus those 80 participants I mentioned from that elder care AF Japanese study, contributed to the first iteration of our cockroach individual participant data meta-analysis of randomized trials investigating anticoagulation in patients with AF and spontaneous ICH. Here you see the four different trials that contributed, as I mentioned. The comparator in these trials did differ in that in eldercare AF it was placebo, in NASPAF ICH it was aspirin, and in Apache AF and SOSTART it was antiplatelet therapy or nothing at all. In terms of the intervention, in SOSTART, it was any anticoagulation, including vitamin K antagonists, but the majority of patients received NOACs. In Apache AF, it was only apixaban. In NASPAF ICH, it was any dosing of any NOAC, but it had to be standard dosing. And in eldercare AF, it was that 15 milligram dose of edoxaban that I mentioned earlier. And what we saw is that this is an older population. 80% were over the age of 75. High risk for vascular events. 40% had a CHAS vascular of greater than 4. Male-female split is about 60-40. Predominantly white ethnicity of the population. And then the type of qualifying intracranial hemorrhage was lobar in a third, non-lobar in 2/3, and then other, including subarachnoid and subdurals, in about 5%. And the median time from ICH randomization was just over 2 months. Now, looking at the primary efficacy endpoint of this pooled analysis, resuming anticoagulation led to a 32% reduction in any stroke or cardiovascular death, but with a insignificant result with a confidence interval crossing the null. However, there was a significant 73% risk reduction in any ischemic major adverse cardiovascular event, replicating again the effect size we would expect when comparing anticoagulation versus no anticoagulation. I'll mention that 2/3 of the control arms in these studies, once they were pooled, received nothing at all as part of no anticoagulation, and 1/3 received antiplatelet therapy. And this was reassuring for us because in the back of our minds, we always worried that would we be able to replicate the 70 or 67% risk reduction in ischemic stroke that we've seen in the original AF trials, because we were, as cerebral small vessel disease contributes to ICH, we were worried that a larger proportion of ischemic strokes during these studies would be due to lacunar stroke, which is less likely to respond to anticoagulation therapy. But these results really reassured us that wasn't a major concern. And then when looking at hemorrhagic MACE, we see a 1.8-fold excess risk of hemorrhagic major adverse cardiovascular events. And these were predominantly intracranial hemorrhages, but again, insignificant with the confidence interval crossing the null. And as opposed to those very large effect sizes that we saw in mortality, in the observational data sets, we actually see no evidence of mortality benefit thus far in this meta-analysis of early phase trials. And if anything, numerically, there seems to be a slight increase in mortality, but again, very broad confidence interval without any clear precision around the point effect estimate. One thing I will mention is that to me, I think the fact that we see very large mortality benefits in the observational data sets that we don't see in the RCTs really further reinforces my concern that the observational data has confounding by indication, and that healthier patients are those being selected for anticoagulation versus not, and why you're seeing that this confounded effect on mortality that we're likely not going to see in the randomized trials. And when we look at different subgroups of interest based on age, sex, and location of hemorrhage, we don't see any significant differences in terms of the treatment effect modification according to these variables. Interestingly, the point effect estimate does suggest harm in lobar hemorrhages in the Apache AF trial, but not in SOSTART. But again, the confidence interval is quite large, and overall, when pooling the data, there was no suggestion of any treatment interaction according to lobar ICH in this data. However, it is worth noting that so far, this data set has only 100 patients with lobar ICH, with relatively fewer number of outcomes in comparison to what I will show you in what was detected by our DSMB in the Enrich AF trial. So what is kind of the conclusion so far based on the summary and the meta-analysis of all the randomized evidence? Well, we still have an uncertain effect on any stroke or cardiovascular death. We produced the reduction in ischemic MACE that we would have expected from the non-ICH randomized trials. The safety is certainly uncertain, and numerically there seems to be excess recurrent hemorrhages with resuming anticoagulation, even when looking at predominantly patients being randomized to NOACs. And really, patients with ICH deserve more evidence to inform their care. Fortunately, there are several randomized trials that have been completed since this meta-analysis or are ongoing. STATISH is a trial led out of the Netherlands, initially by Ivan Berge and now El Sanset. A3-ICH is a 3-arm study comparing Pixaban versus aspirin versus left atrial appendage occlusion, 100 patients in each arm of the study as a phase 2 trial, which will hopefully spearhead a larger phase 3 trial. Prestige-AF was initially powered for about 700 participants, but due to recruitment challenges, they stopped at 300 participants, and they should present their results at the ESOC in 2025. And then the 2 large phase 3 ongoing trials are Aspire, which is an NIH-funded study ongoing in the US, and I'm assuming many of your sites are participating here, which is led by Kevin Sheth and Human Camel. I think there's 2 very interesting aspects of the design of Aspire, which make it a very important trial in this lineup. The first is that it's the only double-blind trial, which will hopefully increase the integrity of the kind of effect sizes and observations of the study. And then the second is that they're looking at only aspirin as a comparator. In North America, it's fairly standard practice to at least consider antiplatelet therapy in this population if you're not going to proceed with anticoagulation, whereas globally there's a lot of controversy in this regard, and this is why all the other global studies and those conducted in Europe have had to allow for either no antithrombotic therapy or antiplatelet therapy as part of the comparator, not allowing a double-blinded design, and not allowing a single antiplatelet therapy as being the comparator, whereas Aspire is able to do both. And this is quite important because someone may mistakenly look at some of the recurrent ICH signals from cockroach and say, well, this kind of negates the argument that resuming anticoagulation is safe in this population and left atrial appendage occlusion is going to be the clear winner. Because remember that if you get left atrial appendage occlusion, specifically if you get it percutaneously through a Watchman device, for instance, you still need antiplatelet therapy for life, if not more aggressive antithrombotic therapy at onset. The cockroach meta-analysis, as I mentioned, 2/3 of the patients in the control arm were receiving nothing. So this excess numerical signal for recurrent ICH is compared to nothing, not compared to aspirin. And this is what we really need, is the safety signal compared to aspirin to then indirectly weigh it against a left atrial appendage occlusion where you need antiplatelet therapy for life. And then lastly, we're leading the Enrich-AF trial, where we've just finished enrollment of 948 participants, are now in purely a follow-up phase to accrue the requisite number of events. This is an event-driven trial, and we anticipate we'll have our 123 primary events that we've calculated would be required to show a 40% risk reduction in our primary efficacy endpoint in the first quarter of 2026. So we hope to be able to present our results at ESOC in 2026 if everything goes to plan. This is some more details on Enrich-AF. Originally, we had estimated a sample of 1,200 participants would be required to reach 123 primary events. However, because of slowed enrollment due to the pandemic, we've actually accrued more events by the time we finished enrollment, and now we only need 950 participants to reach that target. Patients are randomized to standard dosing indoxaban or no anticoagulant medical therapy, which can include nothing, or antiplatelet therapy. Currently, there's about a 50-50 split, 50% receiving antiplatelet therapy, 50% receiving nothing. And as I mentioned, we hope to have our trial results in 2026. This was a large global effort at 240 sites in 20 countries on 5 continents. This is our estimated effect sizes, and that we're expecting a 65% reduction in ischemic stroke, and allowing for a 70% increase in hemorrhagic stroke, and this will ultimately result in a 40% risk reduction in any stroke. I already mentioned our current status, and everything was going gung-ho, and we would have actually stopped the trial probably a year earlier if back in the spring and summer of 2023, our DSMB did not come back, which they did, and indicated that one of our subgroups of interest that we had asked them to look at specifically because we were worried about potential different treatment effect, those patients with lobar ICH or isolated convexity subarachnoid hemorrhage due to underlying cerebral amyloid angiopathy. And what they did when they came back and looked at these patients, once we had about 200 participants with CA-related hemorrhages, was that they asked us to stop enrolling these patients and to stop treating these patients with anticoagulation, because anticoagulation with standard dosing edoxaban led to excess harm that would offset any potential benefit in these patients. Now, we don't, two of our steering committee members were unblinded to ensure that they agreed with the DSMB recommendation, which they did, and that was Bob Hart and Stuart Connolly. And they're no longer involved in study activities. We don't, however, the rest of the steering committee does not know the actual numbers and effect sizes and have remained blinded to this data. However, we did report a letter in Lancet just indicating that our DSMB did found this signal for harm because, as you saw in our survey, about 70% of physicians are resuming anticoagulation in this population, those with lobar ICH, and 30% of those with CA-related bleeding. So we thought it was important for the community to at least know that there was a suggestion of signal of harm that required us to stop enrolling these patients in the Enrich-AF trial. However, 70% of ICH survivors with AF are still eligible. Lobar ICH or convexity subarachnoid hemorrhages only accounted for about a third of our population, and we still need to answer the question in these remaining patients, and hence the ongoing nature of the trial. And then once we finish the trial, we'll show the results for all these different subtypes. Now, was there something distinctly different in Enrich-AF that separates the signal for harm from the cockroach meta-analysis that I didn't identify as the significant excess for harm with lobar ICH patients? Well, the first is that it's worth noting that there was only 100 lobar ICH or isolated convexity subarachnoid hemorrhages in cockroach, and in Enrich-AF we had 200 at the time of the DSMB recommendation, so about double the number. So it may just be that we had a larger sample and the power to detect a difference, whereas the cockroach meta-analysis is not powered sufficiently yet to do so. It's also worth noting that all the other ongoing trials looked at their subgroups of lobar ICH at the levels of the DSMB, and they have yet to find a signal for harm in their lobar ICH subgroups. But again, our enrollment and number of events accrued and follow-up was much further advanced in this subgroup than any of those trials at present. So we'll see how that manifests over time. Now, the other possibility is that perhaps the lobar ICH patients and convexity subarachnoid hemorrhage patients that got into Enrich-AF were maybe a different phenotype, a higher risk phenotype than these other trials, because perhaps the original safety signals that was seen in the SOSTART and Apache AF studies reassured stroke neurologists to maybe enroll more aggressive phenotypes into Enrich-AF. So we've explored this, of course, in a ongoing blinded fashion, and just looking at the phenotypes of MRIs that have been enrolled into the trial. And this is just an exploratory look at the first 171 scans that had blood-sensitive sequences in the study. And one thing you'll note is that the number of MRIs that we received were more frequent in lobar ICH patients versus the total trial population. The reason for this is that we made a very strong push to get as many MRIs as we could in our lobar ICH patients once we got the DSMB recommendation, so we could better understand this excess signal for harm. And that apart from lobar ICH, isolated convexity subarachnoid hemorrhage accounted for about 3.5% of the total population, 5% of the total population, and 3.5% of those with MRIs. So 70% of those MRIs that have been looked at so far did have microbleeds at baseline, strictly lobar in a third, strictly deep in 24%, and then mixed in 41%. The severity of microbleed number is about 40% is 1 to 2, 40% is about 3 to 10, and a quarter is greater than 10. And then cortical superficial siderosis was present in about 26% of the total population, and the majority were focal, 15%, disseminated, 11%. And then if we looked at modified Boston criteria for CAA in all comers with MRI, so at the time of this look, 25% had probable CAA, 5% had possible CAA. And then when we looked at those that just had lobar ICH, what was interesting was that disseminated siderosis was found in 17%. Focal siderosis was found in 27%, and about 44% of those with lobar ICH had some siderosis. So it would suggest that the phenotype of lobar ICH in our trial is certainly reflective of what you would expect in patients with CAA, and there didn't seem to be any selection bias for lower risk phenotypes in our trial, and that it is fairly reflective of all lobar ICH with a high predominance of high risk CAA phenotypes, which may have not been enrolled in the other studies. We don't know that yet. And then ultimately, if you look at probable CAA, it was met in 62% of lobar ICH patients, and possible CAA was 12%. A quarter had no CAA. And then when we looked at the few patients where we had MRIs in patients with isolated convexity subarachnoid hemorrhages, 83% of them had disseminated siderosis, and all of them had probable CAA. So what to expect for the final results of these trials were based on certain numerical trends at present on the phase 3 data. I think the first very clear answer is that we cannot rely on observational data, which is prone to confounding by indication and immortal time bias, and that we're unlikely to see mortality benefit with anticoagulation in ICH patients with AF. We're likely to see excess risk of ICH, and this may be as high as twofold based on some of the data. We cannot assume that the safety seen in DOACs from pivotal AF trials generalizes to patients with ICH, and we really need to test interventions in appropriately powered randomized trials confined to these high-risk subgroups. And that includes left atrial appendage occlusion. And don't forget that patients with ICH are older, they're frailer, they have higher thrombotic risk, they may be at higher risk of device thrombosis, they may be at high risk of bleeding at the time of escalated antithrombotic therapy, early post-device insertion. They may be at higher risk with antiplatelet therapy over time that you require for LAAO, and there has yet to be any RCT evidence of LAAO in patients with ICH specifically. And then another interesting thing is that we may actually find a discrepancy between reducing stroke and then dying. And one thing that we're doing in Enrich AF and in some other ICH trials that we're conducting, the COVASC ICH, is we're actually looking at ICH patient values during trial participation, that how do they value having another stroke versus dying from a stroke or a heart attack, not being independent, having a non-fatal heart attack, or undergoing other ischemic medical procedures. And essentially what we've seen is that actually there may be a slightly increased value of trying to prevent another stroke versus dying from a stroke or heart attack in ICH patients in our SMART sample to date, but we'll have much larger numbers and more refined estimates of patient values at the end of the trial. So what is my practice in the interim? Well, We randomize patients if they're eligible and agreeable to ongoing trials, and I encourage you to randomize to the ongoing ASPIRE trial in the United States. I would also continue to randomize low-bore ICH and CAA patients in ASPIRE because of the discrepancy with what we saw in Enrich-AF and Cockroach. We still don't know, and the signal that was seen in Enrich-AF may have still been a chance finding, and we really need as many of these patients in ongoing trials to have a definitive result in our next iteration of Cockroach, where we're going to pool all these phase 3 trials as well. In patients with non-lobar ICH and non-convexity subarachnoid hemorrhage treated, non-convexity subarachnoid hemorrhage patients, I will treat them with a NOAC and resume anticoagulation. At present, outside of a randomized trial, I will no longer reinitiate anticoagulation. If someone is eligible for left atrial appendage occlusion, I admit that the evidence isn't strong here, but at least I don't have evidence of confirmed harm from a DSMB of a trial. So that's where I'm pursuing. And if someone is not eligible for LAAO, I will consider a lower dose of edoxaban, such as the 15 milligram daily dose that was tested in elder care. Again, we tested a much higher dose of 60/30 in Enrich-AF. And this 15 milligram dose may be safe and has already been shown to be effective versus no anticoagulation. And that's in patients that have high CHA2DS2-VASc scores. If they have lower CHA2DS2-VASc scores, I'll just proceed with antiplatelet therapy. But something that is essential, whether you're going to, irrespective of the pathway you take in these patients, is you want to ensure adequate blood pressure control, which is the highest risk factor for both ischemic stroke and bleeding in these patients. And I get all my patients to use blood pressure home monitoring devices and take a blood pressure diary. And I tell them, call my assistant if more than 1 out of 5 sequential readings on separate days are above 130/80. If they are, my assistant will then titrate with their blood pressure medication through the pharmacy with my guidance. And it's not as time consuming as you might think. And we've established in an ASP-ICH study that this approach does get patients within target on average. Other kind of risk factors for anticoagulation that you should consider and mitigate is avoid concomitant antiplatelet therapy. If you initiate anticoagulation, all this does is increase the risk of major bleeding in ICH without any additional benefit in reducing ischemic events from what we've seen in meta-analyses. Of course, the blood pressure, and then again, consider DOACs rather than warfarin. I'll also mention that even if patients attain their home blood pressure targets, I don't let their GP then continue follow them from there because their blood pressure may creep up over time and then reemerge as a risk factor. This is really nice data by Urs Fischer when he was doing some postdoctoral training in Oxford and looking at the OSVAC study. And essentially what you're seeing is ambulatory blood pressure readings prior to someone presenting with their stroke event. So the stroke event would be actually off this chart and to the left of the y-axis. And what you're seeing is that for both deep and lobar hemorrhages in red and green respectively, you're seeing this exponential increase in their outpatient blood pressures before they're presenting with their hemorrhage. So hopefully with continued monitoring with ambulatory blood pressure monitoring and blood pressure diaries, you can capture them as they're increasing on this exponential line and then bring their blood pressures down before they have their event. And that's my practice for my patients. And then in terms of timing, we really have no RCD evidence. For antiplatelet therapy, there's some observational data that suggests initiating at about a week seems safe. For anticoagulation, it's really anywhere between 2 to 8 weeks. The data that suggests longer, such as 8 weeks, that is being endorsed by the AHA, in my view, is confounded. One of the trials being cited is one where recurrent subdural hemorrhages monopolize the recurrent events, and we know that subdurals have early recurrence in contrast to intraparenchymal hemorrhages. The other study looks at basically a benefit on stroke and vascular death and suggests that the sweet spot is 7 to 8 weeks after the ICH. However, one they screened out and censored all events within the first 4 weeks after the ICH, which is a high-risk thrombotic event risk time period. Two, there was actually no statistically significant increase in recurrent ICH at any time point. There was a statistically significant reduction in ischemic stroke as soon as they started capturing events after 4 weeks. And it was only when they combined stroke and vascular death that they found a sweet spot being 7 to 8 weeks. It really doesn't make any sense why vascular death would uncouple itself from recurrent hemorrhage and ischemic stroke. And to me, it's a strong indication of confounding in this study and potential immortal time bias at the timing of reinitiation. And thus, for those reasons, I actually, for myself, if it's a deep hemorrhage, I wait about 2 to 4 weeks. So if it's a deep hemorrhage, I wait about 2 weeks. If it's a lobar hemorrhage, about 4 weeks. And then if it's a subdural hemorrhage, I'll wait the 8 weeks. To conclude, the dilemma of anticoagulation ICH survivors with AF is certain to increase with their aging demographics. Confounding by indication and immortal time bias limits interpretation of current observational data, and the results from pilot randomized trials have been conflicting. Treatment interactions may exist with ICH location, and predominantly when looking at lobar versus non-lobar ICH. And then large phase D RCD data are required to generate level A evidence to guide antithrombotic treatment decisions in ICH survivors. So I'll end there and open up to any questions. Thank you for your attention.
Thank you so much, Ashkan. This is it's been fantastic. It's a really, it's such an important topic, and we're stuck with these dilemmas on a daily basis. I was going to open it up, to anyone who has questions.
Hello, can anyone hear me?
Yeah, Ali, we can hear you.
Yes, thank you very much for this amazing talk. I apologize that might be not related directly to this talk, but I think the concern that I have is, in terms of newer agents, I know they are overall safe, but I have a question just to see what's your experience or what's your recommendation for the time being for those patients who are currently on factor 11 for trials, such as, I think, they have like for DVT prophylaxis, for acute coronary syndrome, for coronary artery disease, or even for stroke. Any suggestion or any recommendation based on your experience on what to do on those patients if they ever present with intracranial hemorrhage?
Oh, interesting. So yeah, a bit off topic, but an important question. So there's a large number of trials that are currently looking at factor 11 inhibitors. One of them is the oceanic stroke trial that we're leading at a PHRI for either different indications as you outlined. So what if someone has a bleed? Well, fortunately, so far, we haven't seen any excess risk of ICH with these agents relative to even placebo, which is quite reassuring. But patients with stroke will have ICH even off antithrombotic therapy, and this is bound to happen. So the only guidance we have at present is really based on the management of bleeding events in patients who have inherent factor 11 deficiency, and that's hemophilia C, and that includes tranexamic acid and recombinant factor 7. So those would be kind of the two main reversal strategies that have been used in patients with inherent factor 11 deficiency, and what is being suggested as reversal agents if someone were to have a major bleeding when participating in these studies and he wanted to reverse the effect of treatment.
If somebody had a hemorrhage, I'm just curious, what are we going to do in terms of your guidelines and management? It's for the long term, if they needed to be
for
on
factor 11 inhibitors.
Yeah.
To be honest, all the data we're seeing is like, for instance, the rate of intracranial hemorrhage in the Oceanic AF trial, which was a negative trial for the primary efficacy endpoint. But when you look at the safety table, it's amazing how well the high dose of asundexian in that case performed against apixaban, a drug that in similar populations has been shown to have similar ICH rates and similar major bleeding rates as aspirin. And here, asundexian is showing much less bleeding events and intracranial hemorrhage events than apixaban. So of course, we won't know until we actually do the proper trials to answer this question, but indirect comparisons would suggest that asundexian may be safer than aspirin when it comes to major bleeding.
That's really interesting. Wow.
Yeah.
Okay, we have another question coming from Rahul in Tulsa at St. John's. So this is a bit different. So when the hemorrhage is due to an AVM and it's secured, do you still think it is safe to resume a DOAC in the 4 to 8 week time period, obviously considering other related factors and risks?
I think so. I think certainly when it comes to secured macrovascular lesions like AVMs, or even now after middle meningeal artery embolization for subdural hemorrhages, I think we can challenge these patients earlier. We, of course, need to then observe these patients and publish the safety results, but because we don't have hard data, particularly in the latter subdural after middle meningeal artery embolization. But pathophysiologically, it makes sense that you can challenge these patients earlier with anticoagulation once their arterial source has been secured.
Great. There's another question that's come up. I think this is that's come up particularly here in Texas, is with regards to the ASPIRE trial. We wanted to hear your thoughts about this. It's been difficult to recruit into the trial because when a patient's had a hemorrhage and has a fib, we have the option to do left atrial appendage occlusion. And for some of our centers in Texas, that's become almost a standard practice. The cardiologists, there's brain heart clinics that have been developed, and these patients will go to these clinics, and so that option is on the table for many of them. And there's a lot of discussion about should they go in the trial, or and patients are offered these other options. And it seems that the patients would prefer, in many ways, not to go into the trial, but to have their left atrial appendage occluded. And I wondered, if you had any thoughts about this overall. It's just been tough for all of us who are trying to enroll into this trial.
I think it's a common challenge and a challenge in Rich AF as well. The problem is when we start generalizing treatments without evidence within a specific subgroup of patients, right? So the same held true when we were using NOACs in ICH patients without direct evidence of the safety of NOACs in ICH patients. And we're doing now the same with left atrial appendage occlusion, in that we're just assuming that what was seen in non-ICH patients will generalize to ICH patients. So the way I approach it with my patients, as I say, this is an RCT where we randomize to different medical therapies. And there's also an experimental treatment in ICH patients, because it is still experimental in ICH. There's no RCT evidence for left LAAO in this population, where we can close the pouch. And these are the pros and cons of each approach. Forget the fact that there hasn't been RCT evidence for ICH patients with LAAO. Even the evidence in non-LAAO patients is quite, I would say, early, in that there's in total, prior to the most recent publication, there was only about kind of 1,000 patients enrolled in these trials. There was all non-inferiority designs. There was an issue with adjudication of recurrent ICH in the original PREVAIL study that then drove a lot of the benefit that was seen in the meta-analyses that followed, where they were counting subdurals as recurrent as hemorrhagic strokes in the warfarin arm, and not counting subdurals as recurrent ICH in the as hemorrhagic stroke, as they shouldn't have been in the LAAO arm, and the FDA had flagged that. So there was a lot of this, I think, uncertainty as present in regards to the true net benefit of LAAO in non-ICH patients, and there's no RCT evidence in ICH patients. And as such, I conclude that it's still experimental treatment, specifically in ICH patients, and this is the conversation I have with patients about the uncertainty that exists, and whether they would like to get an experimental treatment outside of a study where they're going to provide no evidence for what the right answer is in the future, or whether they would like to get an experimental treatment within a trial where they will actually help answer a question.
Excellent. Another question, they keep coming. So how about in subdural hemorrhages and AFib? Any recommendations on when to resume for patients with subdurals?
Yeah, so if they haven't had middle meningeal artery embolization, I would wait about 8 weeks. And the times I've tried to break that rule, I've found new pockets of bleeding within the existing subdural compartment, or even new foci outside the existing subdural. So I wait about 8 weeks for subdurals. If they've had middle meningeal artery embolization, I think you could probably get away at around 2 to 4 weeks. And then there's various subdurals, right? There's some very small subdurals that resolve on imaging after about a week. That's a very different scenario than the larger subdurals that the hygroma or the subacute component persists for some time. And so that's my approach. I'll mention that there was a study that I collaborated with in Japan where they resume anticoagulation in the majority of ICH patients, and they also tend to do it much earlier than the rest of the world. So they're actually resuming anticoagulation within 2 weeks in the vast majority of their intracranial hemorrhages. In that study, all the recurrent hemorrhages, which was like over 200 patients, all the recurrent hemorrhages were in the subdurals. None of the intraparenchymal bleeds that had resumption within 2 weeks rebled. And that further reinforces some of the other data that's been seen that shows that subdurals have about 20 to 25% risk of recurrence in the early on. And this is why I wait longer in them. Again, how middle meningeal artery embolization changes that paradigm. I would be willing to challenge them sooner, but we don't know. We just don't have the data yet.
All right. And one more question, if you've got the time.
Yeah, 100%.
So Timmy Hodix from Methodist asked a very good question, because she takes care of patients to promote their recovery after stroke, and some of them are on SSRIs for depression, and there is a literature that SSRIs could increase bleeding risk. Any thoughts or any literature about drugs like SSRIs or other drugs that potentially increase hemorrhagic risk in these decision analyses?
Good, very good question. There is observational data that suggests that SSRIs increase the risk of bleeding. More consistent for systemic bleeding, less consistent for ICH. At present, I don't allow it to influence my practice unless someone doesn't need it, of course, right? And this also kind of generalizes to St. John's wort, even omega-3 fatty acids. There's a lot of other drugs that patients take that could potentially increase the risk of bleeding because they have some sort of antithrombotic or antifibrinolytic effect. Statins are part of that as well. But specifically for SSRIs, at present it's not influencing my practice, but we are specifically requesting information on SSRIs in our Enrich-AF case report forms, and we're specifically asking questions regarding other herbal medications that can increase bleeding risk to see if there is any interactions in our trial. So we'll hopefully have a better answer for that after our study.
Fantastic. Okay, I think anyone else have any other questions? No, I don't see any. Okay. Ashkan, we're so grateful. It's a fantastic presentation. It really gives us the up to date where we need to be right now.
Okay. Thanks so much, Sean. It was an honor to present, and I'm really thrilled with the engagement. So thank you.
Oh, you're very welcome. We have about 50 people, and everybody's just, we're getting all kinds of very positive, just thanking you, for your time.
Great.
Okay. All right, everybody, take care. We'll send out the survey so people can get their continuing medical education. Very good.
All right. Thanks, everyone. Bye-bye.
Take care.